I want to begin by thanking the organizing committee to the invitation to be here in lovely Krakow and to see some of you again who I haven't seen for some time and to meet some new friends and colleagues, which is always wonderful. And I think I'd be remiss coming from the US if I didn't make a comment about how Poland has responded to the Ukrainian crisis and how you have taken on the refugees with such compassion and care and welcoming that I think it's inspiring, and you're an example to us all. So thank you for that. So we'll now get to the topic at hand of teaching clinical reasoning, and I will walk through 4 lessons in the literature for you. Yes, you can see my disclosures. The most important one is that I'm a federal employee, so the views expressed are my own, and not necessarily any governmental agency. I do actually have some objectives for today. We'll discuss some definitions and distinctions in clinical reasoning. We'll then review 4 lessons from the clinical reasoning literature that pertain to teaching. And then I will go through some strategies for teaching clinical reasoning for each of these lessons, and we'll form the take-home messages, so to speak, of the sessions. So you don't have to write things down if you were to feel compelled to do so. And actually, I have a handout of the lessons and some teaching strategies for each, if that would be helpful. So I'd like to begin with a little game, and the game is raise your hand. And raise your hand if you think that clinical reasoning has been described as one or more of the following terms in the literature. This game is based upon a review that was done that reviewed over 14,000 articles in the health professions education literature. So there is some evidence behind this question. So who thinks that clinical reasoning has been described as a process? Good. See some? How about an outcome? Some? Yeah. A skill. Lots of people, some going, I'm not really sure, Steve. A task? How about all the above? Some. None of the above. Steve, why are you asking me this question? I'm bringing it up because it's really important, and like a lot of fields in education that are born from multiple underpinnings, multiple disciplines, there is some difference in the definition, and we need to come to some consensus if we want to effectively teach it and study it to move the field forward. So what are some of these definitions from this game that we've been playing? Here you can see some of them, and what I think is important with looking at them is that oftentimes there's more than one term in a definition. So clinical reasoning definitions are becoming more and more inclusive. So for purposes of today, I will define clinical reasoning as the cognitive steps up to and including establishing a diagnosis and management plan for your patient. It begins cognitively when the patient walks in the room and ends when you come up with the decisions that you need to care for the patient at hand. All right, we're going to need to talk about some theory, and I think theory is important as it can help gauge our teaching of clinical reasoning and also help shape our research. And I will start with dual process theory, which I know that Michal, our session chair, talked about yesterday in Polish. And so while I found the session to be very engaging, I'm not sure what you said, Michal, so I'm going to go through some things here that may be repetitive, hopefully not. We're just going to hit some highlights with theory. So dual process theory argues that we have 2 processes for thinking in general. Okay? It was made popular in the book by Daniel Kahneman, Thinking Fast and Slow, for which he actually won the Nobel Prize in economics for this work. Fast thinking in clinical reasoning terms is known as non-analytic reasoning. Non-analytic reasoning is not only fast, it's often subconscious, meaning we have limited introspection, and by definition, it's low effort. In fact, low effort is the sine qua non of fast thinking. Slow thinking in clinical reasoning terms is known as analytic reasoning. It's slow, it's higher effort, it involves comparing and contrasting entities. A related and important theory is that of cognitive load theory, which refers to our limited human cognitive architecture. We can only hold or process a limited number of pieces of information in our short-term or working memory. And our short-term and working memory is absolutely essential for learning and performance. It's been classically defined as 7 plus or minus 2 working memory slots, which is why many believe your phone number is 7 digits long and your license plate has 7 numbers and or letters unless you pay for it to be longer or shorter. But it's an important construct as we look at this, which then begs the question is how the heck do you become an expert in clinical reasoning or in any other cognitive task? And here, some of the solutions that are emerging come from the neuroscience literature, and the concept is that of chunking. And chunking refers to how our human brains constantly associate information. We can't turn it off. It's constantly trying to form patterns and make sense out of what is going on. And when we talk about effective chunking, or what I'll refer to as knowledge organization actually gives us a couple of advantages that allow us to become expert performers. So what do we mean by that? Well, one, you can take several working memory slots that may be, for example, filled with a patient who presents with chest pain, shortness of breath, diabetes, and hypertension, which to a novice learner would take up multiple working memory slots, and compare that with an expert that would have a diagnosis of coronary artery disease, which is a much larger slot that takes up all of those individual pieces. So that's one thing, is it reduces the working memory burden by combining elements that would ordinarily take up multiple slots. The other thing it does, we move from high effort to low effort. So you free up both working memory capacity as well as effort that you can expend in the situation. So these are two ways that we can be helped from doing this. You may ask, well, Steve, how big can the working memory slot be of an expert performer? The answer is we don't know, but it can be truly massive, at least by the literature that's been done so far. All right. I should mention deliberate practice theory, and Michal was talking about simulation and endoscopy and the like, and this is something that from the medical education world has been incorporated into simulation as one particular discipline, some others as well, but it comes also from chess and music and sports, and it's the argument that to become an expert performer, you need to deliberately or effortlessly practice the component parts of the activity, at least initially under the guidance of a coach or a mentor. You may have heard of the 10,000-hour rule or the 10-year rule to achieve expert performance. That comes from deliberate practice theory. I should also mention both content and context specificity. Content specificity refers to the phenomena that you may be very good at taking care of one content area in medicine, for example, coronary artery disease, and struggle with a related condition like aortic dissection. That clinical reasoning is very based upon content. You cannot remove content or medical knowledge from clinical reasoning performance. They are intricately entangled. Clinical reasoning is not a generalizable skill. It is a situational skill. The other topic to bring up is that of context specificity, which is something that Klaus briefly mentioned in his presentation today. And this refers to the phenomenon in clinical reasoning where you actually have two patients that have identical or near identical presenting symptoms and findings. They actually have the same diagnosis, and yet the physician or other healthcare worker comes to two different decisions of what's going on. So something other than the content needed to establish the diagnosis is driving the decision. Clearly a source of unwanted variation in healthcare and error in an area where we can improve in an active area of research. Before I get into the 4 lessons, I think I should also mention one other theory that you heard of. It gets at a theory of knowledge organization. And knowledge organization, when I say this, is effective chunking. It's how information is intertwined or interdigitated, we believe in memory, so that you can effectively, efficiently, and accurately recall and use in practice. One of the speakers Annie spoke about illness script theory, which is a specific theory on knowledge organization, and some of the key characteristics therein, if we think of a diagnostic script, for example, coronary artery disease. Well, what's in a script? It has all the symptoms and findings that you can see in the diagnosis, a range for each symptom and finding, what you would expect, as well as a default, or what is most likely to happen in the current case. It's a form of highly organized knowledge, typically, as we talk about illness scripts, and they're continually refined with practice. And so knowledge organization is like a muscle. If you don't use it, you lose it. If you use it, then you can get better and better. Okay, so here are the 4 lessons that we'll go through. The first being that we require rich, content-specific, organized knowledge in terms of our teaching of clinical reasoning. This is what we should be conveying. It requires a number of strategies, flexibility in strategy use, and prolonged effort or deliberate practice. It's impacted by motivation and emotion, and it's context or situation specific. So talking about our first lesson again, content-specific, organized knowledge. So to provide an example herein, I'd like us to pretend that we're in the cardiology clinic, and you are a practicing cardiologist. For some of you, that may be a dream, and for others, it might be a nightmare, but nonetheless, we'll just play along. And you're working with a student who hasn't been in the clinic before, and this is their first time perhaps even seeing patients in general. And the first patient of the day is a patient with chest pain. The student is very likely to use a slow thinking strategy, again, an analytic thinking strategy known as hypothetico-deductive reasoning. They come up with a hypothesis or diagnosis and then deduce from the symptoms and findings, is that what's going on? So they may think coronary artery disease. Do the symptoms and findings fit? If not, they come up with another diagnosis, maybe aortic dissection. That's the hypothesis. Do the symptoms and findings fit? If not, they need to come up with another diagnosis. Maybe it's gastroesophageal reflux disease. Go back to the beginning, my hypothesis, do the symptom findings fit? And so on and so on and so on. Hopefully you can see how this can be quite an inefficient way of arriving at a diagnosis. It can be accurate. You consider each diagnosis in isolation. It's high effort. It doesn't involve organized knowledge. The steps are not prioritized, nor is the weighing of options. Now contrast this with you, the practicing health professional, in this case, the cardiologist. You're very likely to use a fast thinking strategy known as pattern recognition, which is the highest form of chunking, and the proverbial diagnosis at a glance, because you've seen 50, 100, 1,000 cases of chest pain, maybe in the past month. What's going on with there? Here it's a very integrated approach. Knowledge is very organized and efficient. The effort is low, the steps are prioritized. However, the how did I get there can be difficult for you to surmise, which can make instruction difficult. So as another example, I want you to think of a loved one. Now I want you to think of how they walk, and how they talk, and how they laugh. And I want you to come up with paragraph descriptions for each of those features. Yeah, many of you have given me a facial look like, Steve, you must be nuts. Yes, it's really hard for you to come up with that. But if you were to see them in the busy street in Krakow after a Scotland versus Ukraine football match that happened recently, you'd immediately recognize them. So just because we can't introspect, it doesn't mean that it's not really helpful for clinical reasoning and expert performance. And here's another example. You all can read this slide for me. It's because reading is largely a pattern recognition activity. And this is what we actually want our learners to be able to do in clinical practice. They need to be able to separate the signal from the noise. And so non-analytic reasoning that we know quite a little bit about is actually really important to what we do, and we need to go further here. All right. So I would like to argue that knowledge organization is as important, if not more important, than knowledge acquisition, absolutely essential to clinical reasoning. So you'd say, well, what can I ask my learners to see if they have organized knowledge on a topic? And some questions that you can ask are, can they identify and correct mistakes? Can they compare and contrast between conditions, or do they read and recite information to you in isolation? And it's really needed to free up our working memory space. So we'll go through a couple of teaching points, additional ones, which I actually have in this handout that I'd be happy to give to you, but some common things that you can do. You can actually probe the intermediate steps. It can be really helpful, particularly when they don't give you a correct diagnosis and a justification. So walk back to where their thinking and yours match, and where it diverges, help correct them along the path, help them to organize their knowledge. You can create compare and contrast assignments, which forces them, as referred to earlier by Annie, to refine their illness scripts that they have for related conditions. You can ask them to create prototypic patient assignments where they actually have to pull together, write down, report to you or otherwise, the symptoms and findings, tests and the like that you need to go through to arrive at a diagnosis. You can change key features in the presentation and see if they can go from one diagnosis to another, the so-called what-if questions that can be really effective. You can create algorithms, flowcharts, concept maps, virtual patients. I will not steal Inga's or Dario's thunder, so I will just leave it at that. They can be very effective. It's important that we also give learners time to think, which relates to their cognitive load. We should not just give them the answer or tell them that they're wrong, and also relates to motivation and emotion, which I'll mention in a little bit. We should be discussing essential concepts multiple times in different ways. The practice of medicine is not like flying an airplane. It is very different. Patients are very unique. They need to hear things multiple times to learn them. And because of our limited introspection, we might want to consider near-peer instruction, where perhaps a registrar or resident helps a medical student if it's too far removed for the attending physician. And I think as a final point that I'd like to make here is that because we constantly chunk or associate information, if it's difficult for you to teach, you still should do it, because the learner is learning regardless of your instruction or not. And if we want them to learn it right and form effective chunks, then we have to do the hard work and make sure that we walk them through the process. So that's our first lesson. We'll now talk about our second, that it requires a number of strategies, flexibility of strategy use, and prolonged effort. This actually is a photo of my oldest son, who's now well past college, back when he was in grade school and I was his baseball coach. And so this analogy involves Major League Baseball. Forgive me if you don't like baseball. It probably would work well for cricket and the bowler, and I'm sure for football and the striker, in terms of what I will outline here. And so if we think of a Major League Baseball player, other player, it takes a lot of deliberate practice until you reach that stage. 10 years, 10,000 hours or more if you actually make it. And let's assume that throwing a strike is arriving at a correct diagnosis and management plan for a patient. That Major League Baseball pitcher can throw it fast, and they have a number of fast pitches. Those are the non-analytic reasoning strategies. They can throw it slow, and there are a number of slow pitches. Those are the analytic reasoning strategies. That pitcher is not going to throw the same pitch regardless of the situation if they want to throw a strike, depending upon the batter, depending upon the pitch count, depending on what's going on in the game. And likewise, if we want to be effective in our teaching and our clinical reasoning performance, we need to help our learners with learning multiple strategies and being flexible in their use. It's also needed if you just look at simple numbers, and this slide actually needs to be updated. I'm sure we have more than 25, if not 30 or 40,000 known diseases, syndromes, injuries, tests, medications, treatments, and surgeries. And as I mentioned, your working memory capacity is 7 plus or minus 2. Oh, I'm sorry, I made a mistake. It's actually 4 plus or minus 2 by more current literature. So we're up against a lot. We need to take the teaching of clinical reasoning very seriously if we want to make sure our patients get the care that they deserve. So what are some of these strategies? And I'll briefly mention some. Again, this is just the beginning. Happy to talk more about strategies or anything else, questions that you have. I've mentioned hypothetical deductive reasoning as a slow thinking strategy. There's simple evidence-based medicine. Using best evidence to care for a patient can be done through analytic processes, looking something up. Slowing down your thinking, that's gotten a lot of recent press. Metacognition, thinking about your thinking, right? Using a key feature approach. Key feature approach, different than a key feature exam, actually involves focusing on a symptom or finding that has a very limited differential diagnosis when a patient has multiple presenting symptoms and findings. An example might be focusing in on the finding of splinter hemorrhages when you have a patient with a fever and you're considering a diagnosis like endocarditis. There's ruling out the worst case scenario. Our emergency room physicians and critical care physicians are well adept at this in their regular practice, what might take the patient out of this world. Schemas or flowcharts. Concept maps would be a more elaborate process therein, which Daria will talk about later. The pathophysiologic approach, and Though not done as much, it still exists, a probabilistic or Bayesian approach where you apply statistical principles to patient encounters and calculate predictive values and the like. Fast thinking strategies, there's really two primary ones. Pattern recognition, I already mentioned, and heuristics, which you can think of as mini pattern recognition, at least when it becomes fast thinking. These are useful rules of thumb. For example, consider arthrocentesis in a patient who presents with acute monoarticular arthritis. It's just something that you learn and something that you do and enact. All right, so what about dual process theory and errors? Unfortunately, the dominant discourse still exists around diagnostic error that non-analytic or fast-thinking strategies are bad. And I'd like to argue that any strategy can lead to error or success, and what we need is flexibility. And here's an example. I'd like you to read this slide for me out loud really quickly. Listening? Go ahead. Read it again, focusing in on each of the individual words. The springtime. See, you got it with the second reading, okay? Can you imagine reading a chapter of the book that way, or maybe an entire book that second way? You're like, you're crazy, Steve. It would take me forever. I wouldn't remember a thing. So clearly just slowing down your thinking is not the answer to solving errors in medicine, right? So what are some strategies for this second lesson? I'd like to refer to this as practice makes more permanent. I think the first lesson I mentioned is more like making the implicit explicit as we talk about organized knowledge. So here, practice makes more permanent. What do we do for this? Encourage both processes, non-analytic and analytic reasoning, strategies and flexibility. I mentioned a cognitive forcing strategy where you ask somebody to reflect either verbally or through a checklist. Then we also have to think about the deliberate practice aspects. Longitudinal mentoring is in line with, certainly with deliberate practice. We need to help learners with what activities to practice. We need to teach them what's relevant versus what's irrelevant, typical, atypical. Emphasize common causes and big picture concepts. Thinking out loud. We heard a presentation where you could do this on podcasts, which I hadn't actually anticipated before, which is a really cool way. But this is basically connecting the dots with your thinking, with the learner being present. So explain to them how you got from point A to point B, why you think this is a diagnosis of aortic dissection, and how you got there and what you're going to do. Can be really helpful to learners herein. Provide frequent feedback over time in small amounts, which really gets at cognitive load. All right, moving on to the third lesson, that it's impacted by motivation and emotion. I think appropriately, a lot of schools focus on the cognitive factors with teaching clinical reasoning, if they do it explicitly at all. And that, cognition and clinical reasoning, analytic, non-analytic reasoning, script theory, cognitive load, all very helpful in terms of planning your teaching of clinical reasoning. But there's more to it than that, and fields outside of medicine and now in medicine are actually showing the importance of emotion on cognition. And importantly, cognitive loads plus or minus 2 that I've mentioned is actually driven by emotion. So it's something that we can enhance, a quote-unquote superpower, or something that we can suppress, and it'll make teaching clinical reasoning even harder. So we should be thinking about effective behaviors and learning behaviors and effective factors in our teaching of clinical reasoning. Let's use the science. So what can we do in terms of teaching strategies to help with this lesson? One, we need to optimize the learning environment. Keep in mind that things like burnout and sleep deprivation, which is unfortunately prevalent in the United States and perhaps elsewhere, has detrimental impacts on working memory capacity and thus learning. We need to optimize engaging and relevant work activities with appropriate support. We need to give our learners progressive independence, giving them increasing responsibility as they are ready and able with our help and support. We should capitalize on emotion with learning. Again, it can be a superpower. What are some ways we can do that? Well, one is actually having learners teach each other and teach you and giving them feedback. Another is, I think quite evident, is telling meaningful stories, teaching clinical reasoning around actual cases. when learners are ready to do so. I think it's another example of emotion's power on learning and memory is to ask you the question, who here is fairly confident of what they were doing, say, 5 days ago between 9 and 10:30 a.m.? Any clue? Right. Who is fairly confident of what they were doing when the pandemic, when they first heard the news about the pandemic and the impact on their practice? Any hands? For those of you that are old enough, do you remember what you were doing when the planes went into the Twin Towers on 9/11? Fairly confidently? Yeah, I know that memory is not fully accurate. We've already heard about that, that it's true, but we should capitalize on emotion. It can really help us. We should be encouraging learners to commit to diagnoses and therapies, which again increases attention for them. All right, and again, working memory is allocated and directed by motivation and motion. Finally, the fourth lesson, that context or the situation specifics matter. All three of the prior lessons apply to this notion. And importantly, we should consider other things in the situation that can drive clinical reasoning, teaching, and performance. What are some of those things? How much time does the learner have to see the patient? Who else is on the team that they can work with? Consultants, nurses, technicians, others, for medical students, residents, and faculty. Does their technology work? And as mentioned in the first session, do they know how to use it? Point of care resources to help with diagnosis and management, their electronic health record or EHR. We should be mindful of the impact of system on error and performance and should be teaching towards that to help our learners. We should not assume that experts, quote unquote, will display expert performance. Just because you are a qualified expert, quote unquote, in a given specialty doesn't mean that you know the answers to every patient that you see. Performance is more of a state than a trait, in part because clinical reasoning is not that generalizable. And so I'll leave you with, is the world inside the head or is your head inside of the world? I would argue it's the latter. That we should be paying attention to the environment, the interactions that we have, the system that we work in addition to the earlier lessons that I mentioned about knowledge organization, flexibility and strategy use, deliberate practice, motivation, and emotion. So I will end it there, and I think I ended with some time to spare, if I'm not mistaken, Michał.
Well, obviously cognitive errors do not apply to people who study them, which is obviously a huge cognitive error that I just made, but there are questions to you.
Good.
And they are interesting. So I think we will sacrifice a little bit of lunch break rather than the content of the conference, because I still do hope that we came here for the content, not for the lunch, but that might be another error that I made.
No, it's good.
In your opinion, what's the best method to assess clinical reasoning? Since I believe we need to know, if we are making any progress.
Sure. I'm happy to wax on the assessment of clinical reasoning. And I don't think you're going to have a single metric. Mm-hmm. So if we just walk through the lessons and organize knowledge and understanding that there is content specificity, I actually believe, and I know some people disagree with me, that multiple choice questions can be helpful because they actually enable you to sample multiple content areas in a field in an efficient and effective way so you know if they have knowledge and can apply it. Beyond that, I think that direct observation can be really important and helpful. So it can get at multiple strategies, flexibility and strategy use. You can capitalize on emotion and motivation, and you can actually bring it to the situation, context specificity. And I think there are a number of ways of doing that. It can be everything from the teacher sits and watches the learner and provides regular feedback. It can be asking them to think aloud, as we talked about, from time to time to get that narrative story from them. It could be going into the simulation setting and having them go through a couple of critical stations to help you. But being mindful that whatever content areas you're sampling for these other lessons, you need to be aware that you need to sample lesson one, or knowledge and its organization, because clinical reasoning is that dynamic. So that's what I would do, is a series of assessments. I actually like doing a lot of formative assessments or programmatic evaluation at lots of points in time, as was mentioned by Claus, in real time, and getting their feedback and helping them improve. And so we do multiple things. So it's not a one answer. Hopefully that's helpful to the listener, and I'd be happy to provide additional things. I didn't mention concept maps and virtual patients. Again, another way to get at some of these other lessons we talked about. So there's lots of things you can do, and they have different time and resource and faculty development needs. So you need to figure out what's best for your system.
I think the take-home message could be that multi-source planned evaluation, and I fully agree that there is nothing wrong with MCQs. It's probably with our use of MCQs that there's sometimes a problem. Okay, a little bit controversial question, I think, but how much do you think those theories should be understood by our learners?
Yeah, so it's a really great question. I think the general principles behind the theories can be really helpful. It can help provide a guide or a structure to the learners. So if I sit and explain when I'm on the wards a patient that I saw who was admitted and the different strategies that I go through, and actually illustrate and talk to the learner about that, I don't care that they actually know the names of these strategies, but they know that they exist, and then they start thinking and practicing them. I make it very evident in terms of motivation, emotion on the wards, that I'll tell people when things went badly. I think as attending physicians, as we like to call them in the United States, where we're best is where we've been burned or nearly burned. Those are the cases we remember, and that's what we share with the trainees. Again, emotion and learning to help. So it would be some things.
Wonderful. Thank you very much. We have to proceed.